Hello, my name is Claire Harrison. I'm a consultant haematologist at Guy's and St Thomas's Hospital in London, the UK. And I'm going to discuss in this video key challenges and best practice recommendations in pregnant patients with MPN. So is pregnancy an issue for MPN patients? Yes, it is. Around 20 to 30% of our patients are of childbearing age or potential, and this is something that does come up frequently for these patients. Particularly common, pregnancy and pregnancy discussions are particularly necessary for young women, of course, and the most common MPN type that these patients have is usually essential thrombocythemia. And certainly we know most about ET in pregnancy, and then probably after that polycythemia vera, and then myelofibrosis, and much less about the rarer MPN entities such as MPNU and prefibrotic myelofibrosis. Before I forget, I also want to mention the importance of liaising with obstetric colleagues, because sometimes patients do present in pregnancy, and they may present, for example, with a pregnancy problem as a first manifestation of their MPN. So it's important to maintain open channels of communication with your colleagues in the obstetric service. And actually going forward and thinking about the management of your patients when they're pregnant, it is very useful to have a combined approach with obstetric services. In our hospital, we have an obstetric clinic, which is run by a haematologist who has expertise in MPN, as well as an obstetrician. So what we know about MPN and pregnancy is that for the most part, pregnancy will be successful, but that there is a higher risk of pregnancy-associated complications, in particular those occurring in the first trimester, such as early pregnancy loss, and then later in pregnancy, issues such as preeclampsia, intrauterine growth retardation, abruption, etc. For the most part, these problems result in adverse outcomes for the fetus, and most recent data actually suggests that maternal complications are quite rare with modern management. So what is best practice modern management for MPN in pregnancy? Well, first of all, it's to be preemptive where possible and to talk to your patients about pregnancy and indeed contraception, thinking about what might be appropriate for them. When I talk to my patients, I just ask them if they're planning a pregnancy to have a conversation with me, and that would include, of course, male pregnant patients as well as female patients. For male patients, just to touch on briefly here, the main issue is really about what drug they're taking and risk of teratogenesis. For female patients, ideally we would want to plan in advance of pregnancy, have a meeting to discuss what might be necessary to change for pregnancy. For example, if they're taking a drug such as hydroxycarbamide, which can't really be taken in pregnancy, or indeed an acrolide, then it's important to have a conversation with them about that, and also about anticoagulation if they're taking it. Broadly, I divide pregnancies up into high and low risk. A low risk pregnancy is a patient who has low risk disease anyway, so no prior thrombosis, platelets, for example, for ET patients less than 1,500, and similarly for PV, and probably a white count of less than 20. And those patients can generally be managed in the same way as they are pre-pregnancy, with aspirin. And for PV patients, an important factor is that they should have a lower target hematocrit. During pregnancy, these patients would be a little bit more intensively monitored and have a fetal growth scan with assessment of the placental circulation at around 20 weeks. If placental circulation, as determined by pulsatility index, is normal, then they can proceed and have growth scans later in pregnancy, but pregnancy is likely to be uncomplicated. For high-risk pregnancies, which are defined as patients who are high risk anyway and currently taking a cytoreductive drug, Or there are some extra categories for pregnancy. These include patients who've had 2 or more first trimester losses or 1 late pregnancy event in the past. These patients require management with a cytoreductive agent and, for the most part, an anticoagulant, which is usually low molecular weight heparin. The exception for the anticoagulant is the patient who's been treated just for very high blood counts. There are some patients in this category who would require additional assessment before pregnancy. These include patients, for example, who've had extensive prior thrombosis, for example, in the splanchnic bed, where you might want to discuss and work with the liver team to ensure there are not ongoing issues with portal hypertension. Otherwise, these patients proceed through pregnancy with scans, as I discussed, for low-risk patients, and are then managed through the time of delivery with particular attention to anticoagulation. For all patients in the postpartum period, we would usually recommend at least 6 weeks of anticoagulation, usually with prophylactic dose low molecular weight heparin. But of course, if they're normally fully anticoagulated, there will be a higher dose. Breastfeeding is recommended for patients, but there needs to be a specific discussion about the use of interferon, as this is excreted in the breast milk in low doses, and also consideration for aspirin therapy, since this is also excreted in breast milk and may cause some issues for young children. So those 2 things need to be specifically discussed with your patients. We know a lot about outcome for MPN in pregnancy, and as I mentioned, for the most part, this is successful, with more than 80% of pregnancies in modern series being successful. But it is useful to try to maintain national and international registries for these patients and understand how we can improve these outcomes further. I wish you every luck with managing your patients in pregnancy.